everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we have a interventional pain specialist with us, Dr. Roshan Chhatlani. Hi, welcome.
Hey, thanks for having me, Dr. Marius, Deanna.
Yes.
It's a pleasure to be here.
I'm so glad to have you on. And we're going to be talking about interventional pain specifically. If you listen back, we've done an episode on how to manage chronic pain, and we're probably going to dabble a little bit onto that. But I just want to specifically talk about this profession a little bit today and educate our listeners and talk about the difference between traditional pain medicine or pain management and interventional pain management. So why don't you go ahead and tell our audience a little bit about yourself and how you got to where you are today?
Awesome. Thank you. So first off, my name is Dr. Roshan Chhatlani. I'm an interventional spine and pain management physician, originally from Long Island, New York. I did my undergrad at the New York Institute of Technology, did my medical school training at the New York Institute of Technology, College of Osteopathic Medicine. Then I did my residency in physical medicine rehab, which I'm sure we're going to go over in a little bit. Then I did my fellowship at interventional spine and pain management. And kind of just going back to my specialty specifically, to go to this route, you either have to do anesthesia training or physical medicine rehab. And I did the physical medicine rehab route, and that really kind of gets us into this topic.
Awesome.
Yeah, we see so much pain in our practice. And one thing we've noticed is that there's so many different approaches and so many different ways. So typically spine surgeons want to do surgery, and that's not necessary in most cases, right? So there's so many things that you can do first before you go the surgical route.
Yes, definitely. So a lot of people don't realize that this specialty exists, and that's kind of a big part for us physicians. We have to really educate our primary care physicians, right? Because you guys are in the front line. You see the patients from A to Z, you see all the issues, and we're that halfway point, right? From primary care to a surgeon. And of course, there's always a situation where the patient needs surgery, but most of the times, and a lot of the times, they should go through us first, right? Because we can always do the conservative management, physical therapy, obviously anti-inflammatory medications, and even injections and procedures that we'll go through today.
Is there anything particular that drew you to this field?
Great question. So I was very confused going through med school. I really wasn't sure what I wanted to do. I actually didn't want to go into a surgical specialty. I knew I liked orthopedics, and not orthopedic surgery, but non-surgical orthopedics. And I think physical medicine rehab is a great field for non-surgical orthopedics. And this even goes back to patients with any pain in the spine or peripheral joints. We're really good at weeding out the diagnosis and the treatment plan. And it's awesome, especially back pain specifically. It's like a puzzle, right? So it's not very straightforward. You have to do a good history, good physical exam, and that really helps guide you to the treatment.
And I think it's was a little confusing for patients because it used to be called sports medicine. And so patients used to always say, well, I'm not into sports. Why would I go there?
Yeah, no, exactly. It's very true. So I have so many patients that I see that once they come and see me, they're so impressed, and they come back for other joint pains. Because a lot of people think they just have to live with these pains. They think surgery is the only option. But again, there's so many things that I offer that I can help patients with.
So can you explain what is interventional? What's that mean?
Great question. So for this answer, I think we have to go back to more of the traditional pain medicine route. Okay. And I'm sure a lot of you have seen the Netflix series based off Purdue Pharmaceutical.
There's a few of them.
Yep.
Actually nowadays, but yes, I saw that one.
Yeah.
Poisoned?
Dope Six one. Yeah.
Okay. Yeah, there's several.
Yeah, there's a bunch. And it's a hot topic now. So it obviously reflects the late 90s and the early 2000s with the misuse of drug medications and patients getting overprescribed medications, and unfortunately, there's no good pain medicine. They're very addicting. They cause constipation, respiratory depression, and they're really not always the best option for patients. But of course, there is a place for it. But interventional pain is a field where we actually target the root cause of a patient's pain, and it's a great option for patients.
Great. I like that. We're all about the root cause, right?
Absolutely.
Yep.
So I like how, a lot of times, we just want to say, oh, you have pain, here's an anti-inflammatory, here's just a pill or something to take away the pain, right? But let's talk about some of your treatment options and what do you see in your practice most?
Yeah, so I focus mainly on the spine, so neck, mid back, low back. I also do peripheral joints, hip, knee, shoulders. And again, the big thing is first, I always tell my own patients, we do a thorough history, right? So it's very important how the pain originated. Was there an inciting event? Was there a fall? Was there trauma? Was it a motor vehicle accident? Did it happen all of a sudden or was it gradual? All these questions we ask, does the pain shoot down the legs or it stays in the back? All these questions really help pinpoint us to get to the right diagnosis. And again, getting the right diagnosis gets us to the right treatment plan. And then the big thing is physical exam. That's what I really am happy that I'm a physiatrist, I'm a DO specifically, because we really believe in examining our patients. So physical exam gives you a lot of detail. So I ask half my patients, like, do your physicians touch you? And a lot of them are like, no. And obviously insurance plays a role in just things of that nature, but it's very important to do a good physical exam. So, and then imaging. So any patient who comes and sees me, we get x-rays, whether it's the spine or peripheral joint, we take a look at the bones. That's the first step.
And you can do that right in your office.
Yes, we have x-ray right in the office. And then if we need to, we order an MRI, which we don't have in the office, but we send the patient to a nearby facility. And then the big thing is once we get the advanced imaging, I review it with them. So every exam room in our office, we have huge screens. We go through the imaging with the patient. I have a lot of patients who are like, oh, never had my images reviewed before. And this even comes back to, I know, primary care physicians. You guys order like MRIs, CT scans. And I have patients who say like the primary care doctor didn't even go over the report.
Which brings up a question. Does every patient with back pain need an MRI?
Great question. That's not every single patient. If it's a simple lumbar strain or sprain, it's treated conservatively. Physical therapy, non-steroidal anti-inflammatory. But again, if they have more pain shooting down the legs, which is also called radicular pain, it's very important to get an MRI. And that really helps me guide my treatment, right, for the advanced procedure or whether it's an epidural or simple injection.
Can you explain for our listeners what the difference of, like, why do you do an MRI and not a CT scan? And do you need an x-ray before an MRI?
Great question. So you definitely need an x-ray before. Usually insurance requires it, right? And you also need to do physical therapy for 6 weeks, right, before an injection is even approved. But the MRI and CT is advanced imaging, so I need that before doing any advanced procedure. MRIs, I prefer MRIs. It's more for radicular pain or pain shooting down the leg because that shows us the nerves, the soft tissues, the spinal cord, the disc space is better. CT scans are more for patients who had prior procedures or hardware because the CT scans evaluate the bones more than the actual nerves and soft tissues and disc space.
So like a prior procedure, like if somebody already had, what do you call it? Like a lumbar fusion, exactly. That, and they might have plates or not plates, a rod, right? So you would prefer a CT scan for somebody like that, maybe?
Yes, definitely. So they're looking at the hardware, looking at the bones. The CT scan is the way to go. And also, patients who have pacemakers, they usually need a CT scan or a certain hardware in their body elsewhere.
Right. Okay, great. And can you explain radiculopathy for our listeners out there?
Yeah. So radicular pain is basically pain shooting down the legs or the arms. So especially in the legs, I know we all heard the word sciatica before. Sciatic pain, so it's a pinched nerve that causes pain that goes down your legs. And then there's also cervical radiculopathy, which is in the neck, where you have pain shooting down the extremities of your arms. Yep.
And if someone has neurological symptoms such as a foot drop or weakness, then it's a different case, right? It's no longer treated as the same.
Exactly. So it's really important, again, going back to the history, the physical, when did the foot drop start? Was there any inciting event? So that also really guides my treatment plan as well. And seriously, if a patient has like a weakness, they have foot drop, it's also, they might also need to get a surgical referral as well. So it really, again, guides the assessment plan for me.
If somebody has some neuropathy, whether it could be diabetic neuropathy in their feet or their hands, or say it could be any type of like numbness or when I say neuropathy, that's like nerve pain, right? Or numbness or tingling in their hands or feet. Do you have a solution for that?
Yes. So again, it really goes back to what is causing the neuropathy or nerve pain, right? If it's a disc bulge in the neck or the back, it could be a herniated disc, and would be helped treated with an epidural in the neck or the back. If it's painful diabetic peripheral neuropathy or like a post-herpetic neuralgia, is different types of treatments. We have the Qutenza procedure, which is topical capsaicin. It's 8% medical grade topical capsaicin. It's a procedure we do in the office. It's just a 30-minute application of putting the topical patches. And the research and data is amazing for it. And it's improved by insurance, number one. So it's not you don't have to pay out of pocket for it. And a lot of our patients, we repeat it every 3 months, and they do really great.
It's just one treatment every 3 months?
Yes, one treatment every 3 months. And these patients, they have severe burning, numbness, tingling in their feet, specifically the painful diabetic peripheral neuropathy patients, and it's life-changing for them.
And do they get relief within a matter of like minutes after the session, or does it accumulate, or how do you explain?
Yeah, some patients do, but sometimes it takes a week or two to fully kick in.
Okay.
Yeah.
Is the patch applied at the level of the spine or more towards the feet?
Yeah, so for the painful diabetic peripheral neuropathy application, it's done where the burning, numbness, tingling are in the feet. So we usually ask our patients, where do you have the most symptoms? And we just apply the patches there. We usually do 2 on each foot. And then for the post-herpetic neuralgia patients, we do in that dermatomal distribution.
Right, which we've talked about shingles before on our previous podcast. I'll go back and listen to that. But post-herpetic neuralgia can happen from having shingles, and it can be very painful, and it can last for who knows how long.
And we didn't talk about that procedure because we didn't know about it.
Right, so that's very good to know. Now, can you use that same technique on hands, or is it mostly for feet?
It's mostly for the feet and the painful diabetic peripheral neuropathy.
Can you explain what an epidural is?
Great question. So an epidural, I know a lot of my patients when I come in, I'm like, hey, have you had an epidural before? They're like, oh yeah, I had it in pregnancy, which a lot of women do for pain management. But the epidurals that we do in interventional pain, they're targeted. We do it with X-ray guidance. That's our navigator, X-ray machines. And we pretty much guide one needle. We numb up the skin. We guide the needle to that epidural space. We put a bunch of steroid and numbing medicine. Steroid's anti-inflammatory nature, and numbing medicine numbs up the area. So usually when we do an epidural for neck, mid back, low back pain, I always tell my patients you expect to be here for an hour. It's usually a couple minutes long. Again, we pre-op them. They come in the room, they lie on their stomach, and with X-ray guidance, we numb up the skin and we get to the spot. We put the medicine in, and then we monitor them for a few minutes after the procedure. And then we usually send 3 weeks after the procedure because the steroid usually takes a week or two to kick in. So usually by the 3-week mark, we really know if it helps.
How often can an epidural be repeated?
So usually you could do 3 in a year. That's mostly because of insurance reasons.
It's not because of the high steroid dose, or?
No, it's more for the insurance.
Okay.
It really depends, the patient to patient, because you also have to worry if they're diabetic, is their blood pressure controlled, because those are usually the things to watch out for repeating the epidurals.
Right. As we know, like with steroids in general, diabetics, the sugars can go up. You can crave more sugars or carbs. You can get irritability, difficulty sleeping. And then for blood pressure could go up as well, right?
Yeah, so. No, exactly. And I also want to touch on, I know steroid gets a bad connotation usually, but a lot of my patients, what they don't realize is the steroids that we do, it's much less steroid, and it's like targeted to the root cause of their pain. It's much better than steroids by mouth or like a Medrol dose pack. That's a lot more steroids. And it's dissolved and absorbed systemically. As opposed to the epidural, it's putting water on the fire. That's what I tell a lot of patients. So like my job is to find where the fire is using history, physical, advanced imaging, and then we put water on the fire.
I'm glad you mentioned that. I was actually going to ask. So say you have to go to the like L4, L5, which is lumbar vertebral 4 and 5
body,
location. So say you pinpoint it to that area and you're going in. Does the steroid just do you inject it to the nerve, around the nerve? Is there just a sheath, or what's your goal for that? I was always curious about that.
It's a great question. So there's different types of epidurals. We didn't really speak about that. There's an interlaminar epidural, which is getting right outside the epidural space between the lamina of the vertebral bodies, going to a little of the anatomy. So usually do more injections for patients that have symptoms on both legs. But if they have just right-sided radiculopathy or leg pain, we do something called a transforaminal epidural.
Okay.
And it's, as the word trans, so it's between where the foramen, where the nerve exits. So specifically, you target the left or right. It's a selective nerve root block.
Great. It's like on that side.
Exactly, yeah.
Okay.
And what's the downtime after an epidural?
So I just tell my patients no gym for 48 hours. The first 24 hours, just take it easy. Let the medication take its effect. Sometimes patients have a little sensitivity to steroid, which happens. So I have patients take it easy the day of. And the next day, if they're doing really well, and some patients, like I said, it could get immediate relief, or it might take a week or two to kick in for the steroid. But day 2, if they're feeling pretty good, I tell them they could ramp up their activities. They could still do their errands, go shopping, go for a walk.
Do they need to ice the area when they get home?
Yes, we usually tell them ice or Tylenol.
Okay. And is there a chance of like a steroid flare? Because I do some joint injections and I always caution on that.
Yes, so that's definitely usually the most common side effects we see. You see flushing in the face, you can feel a little dizziness or headaches. For patients who have those steroid type flares, we usually pre-treat with Benadryl.
Okay. Or can they have like worsening pain before it gets better?
Yeah.
Kind of thing?
Yeah, especially like sometimes, and that's another thing with these epidurals, like the transforaminal epidurals get really close to the nerve roots. And that can usually cause an increase in pain because we kind of reproduce that pain in the office. And it takes a little time for it to subside, but usually they get more relief.
Okay, great. And what else do you all do?
Great question. So we kind of went over the Qutenza procedure, which is one of our really good procedures for painful diabetic peripheral neuropathy and post-herpetic neuralgia. We also have the Intracept procedure. I'm not sure if you guys have ever heard of, if you looked at MRI reports, have you ever seen modic changes at all on the reports?
No.
So the vertebral bodies, the end plates, there's something called modic changes, increased signal. So it's usually fluid or edema, and that causes a lot of pain at the end plates.
Like bone signaling.
Yes.
Okay,
yeah.
I've seen that. Yes.
Yeah,
Okay.
you've seen like Schmoll nodes too that
Yes.
are active, like hot Schmoll nodes.
Yes.
Usually they're fluid filled and they cause a lot of pain. So it's a procedure where we do in our surgical center. So it's not in the office. So we didn't really go about that, but the epidurals we do them in the office, but these more advanced procedures we do in the surgical center. So it's a procedure, takes about an hour long. Patients are sedated for it. It's just going in. We do it minimally invasively. So it's smaller incisions, very small tools. We just get into the vertebral body, right, using minimal invasive tools. And we go into that area with x-ray guidance. We burn the nerves for about 14 minutes. And then we come out. It's like a root canal. So it's the basovertebral nerve. That's the nerve that provides the pain signals for those end plates. And we go in, burn those nodes, come right out.
Is that the same as a rhizotomy, or is that something different?
Rhizotomy is just it's a similar concept, like an ablation. Yep.
Okay. So if somebody says an ablation, it could be either of those.
Yeah. So
Okay.
yeah, exactly.
And
Different
is there
technique. Rhizotomy is a different surgical technique, but they're both getting rid of the nerves.
Okay.
And that's not permanent, though, right? Is that something that has to be repeated?
Great question. So for this procedure specifically, the basovertebral nerve is unmyelinated. So once you burn it, we do the ablation, it doesn't grow back. So it's a really good long-term. The patients that we choose for this procedure do great. And that's another big concept. Like every patient, you have to choose the right patient for the right procedure for the right patient.
Right.
Yeah.
Any other procedures that you specifically specialize in or like doing in your office?
Yeah, so a couple more advanced procedures we do is the reactivate procedure. I'm not sure if you guys have heard of that.
No.
So it's the multifidus muscle restorative treatment. So it's a procedure. I don't know if you ever noticed on MRI reports, maybe like a multifidus muscle atrophy.
On the back?
Yes,
On the spine?
yes, yeah, exactly. So it's your paraspinal muscles. So
Right.
these patients, they have weakness in their multifidus muscles, and you can see them on the MRI findings on the T2 axial cuts. So there's a lot of fatty deposit. So it's something called
So it's typically up in the thoracic spine?
lower
it's
back,
in
lower
lumbar.
back, yeah.
Okay,
yeah.
lower.
So it's usually chronic pain greater than 6 months, pain that stays in your back, which is axial pain.
Okay.
These patients have a positive, obviously this physical exam maneuvers as well that we examine in the patient in the office. And then they have the multifidus atrophy on the MRI. So that chronic band-like pain on the lower back. And it's a procedure where it's an implant procedure. We do again in the surgical center. We implant 2 leads which stimulates the L2 medial branch, which is the motor nerve that stimulates the multifidus muscle. And it's literally doing the physical therapy from the inside out. It's like having an internal physical therapist. We also implant the battery as well. And again, so it's 2 20-minute sessions. So we do the implant procedure. We see the patient back in 2 weeks in the office, and we turn on the stimulator. And they're able to do the 2 20-minute 30-minute sessions a day where they lie on their stomach and they turn it on. And it literally stimulates those muscles. And I tell patients, just like going to the gym. So it's not a instant relief, but it usually takes a few months. And the patients we've implanted, they do really well.
So this is different than a spinal stimulator.
Exactly.
Spinal root.
Spinal cord stimulator, yeah.
Right, exactly. Because we did a podcast as well on that.
Yeah.
And that's more for pain control.
Yes.
But this is more for repairing and rebuilding the muscle then.
Exactly. And I'm a physiatrist, physical medicine rehab, and this is really speaks to what my training is.
And so this implant stays in them?
Yes.
Okay.
Yep.
For how long? Forever?
It could be for life, yeah.
Okay.
So all the patients, me and my partner, Dr. Anthony Giuffrida, none of the patients have wanted it out. They love it. And again, it's doing the physical therapy from the inside out.
And I assume the battery has to be changed after a certain amount of time?
Yes.
Okay. But that's simple with almost any of the stimulators
Yep.
out there, right?
Yep.
So wonderful. Oh, keep going. What else?
So we also have the mild procedure. Have you guys heard of the mild procedure?
I've had a few patients who've had that done.
Yeah. So the reactivate Intracept is more newer, but the mild procedure has been there for a while now. It stands for minimally invasive lumbar decompression. So it's a procedure, again, going back to the MRI report, in the lower lumbar spine, if you notice ligamentum flavum hypertrophy.
Yes.
So it's the ligament posteriorly, and that contributes to the stenosis. Stenosis is another word for narrowing. So it's a procedure where we go in and we remove the excess ligament, and it helps decompress that area. Yeah, and these are patients who have something called neurogenic claudication. Neurogenic claudication
Yes.
is have patients who, and I'm sure whoever listens to this, I'm sure you might be suffering from this, patients who walk for prolonged periods. They have weakness in their legs. They have numbness in their legs. They need to take breaks. They need to sit down.
And how long does that procedure take to do?
And it's within an hour as well.
And that's also seen on an MRI.
Yes, you see those findings in the MRI, and again, involving the history and physical, and choosing the right patient for the right procedure.
But it's different than just spinal stenosis, central canal stenosis, right?
No, this is, central canal stenosis with neurogenic claudication, symptoms.
Because I thought the ligamentum flavum is associated with the spinal canal stenosis?
Yes.
Okay.
Yep.
Okay.
Yeah.
I thought they were two different things. So we cleared that up. Great. And so you go in, I always say the roto-rooter. Is that basically what you're describing then? You go in and clear out the stenosis part inside the canal?
Yeah, so the stenosis could be due to a disc herniation in the front in the anterior column, but this is where the ligamentum flavum is in the posterior column. So it's kind of clearing out that ligament from the posterior aspect.
So it depends on the location.
Exactly.
And what if it is in the anterior column? What do you recommend for that then?
Really depends. I mean, if they're having, you'd of course do an epidural first, right? Because they're having symptoms down the legs. So that's the first step.
Okay, to reduce the inflammation.
Yes.
Because as that stenosis is comprising or pushing on the nerve, it's creating inflammation.
Yep.
Right. So an epidural can help or buy some more time. Right?
Exactly. Yep.
Okay.
And one thing that we talk to our patients about is that not all herniated discs cause pain. Lots of people are walking around with herniated discs and have no problem at all. And then when it gets inflamed, they have pain, and then it can still get better, right? You don't have to have surgery just because you have a herniated disc.
Exactly. Great question. So great comment, rather. So a lot of acute disc herniations, usually in the pathophysiology, usually within 6 weeks, you feel better, even if you have an acute disc herniation. And I tell my patients with their back pain, like it's a lot of ups and downs. One day you'll feel really good. The next day you'll feel 10 out of 10 pain and you'll be in bed. So it's very important to do what you can do. So the biggest thing is physical therapy. I tell all my patients, the goal of injections is to get you to do more physical therapy. The goal is to never stop doing, of course, a good course of physical therapy is twice a week for 6 to 8 weeks. But once you kind of get the exercise down, you can do it at home.
Yeah.
Do you find that core strengthening helps back pain?
Yes, huge. So core strengthening, it really helps offload your spine. So usually our PT prescription includes paraspinal muscle strengthening, stretching, core strengthening, home exercise program. That's all very important.
Yes. And can you tell us a little bit more about how your rehab background has influenced what you do these days?
Yeah, great question. So physical medicine rehab, for those who don't know, it's a field that's very, the big emphasis is on a multidisciplinary approach. So you have physical therapists, occupational therapists, speech language pathologists, case management, social work. We help patients get back to activities of daily living. And that's the goal, to get patients to live a pain-free life and doing much better. And during my residency training, we did a lot of team meetings, right? So we help really guide the patient's treatment and plan. I think that's really helped me in interventional pain and spine, just really targeting the root cause of the patient's pain and really getting them back to what they love to do.
Do you guys still kind of have like a team approach within your practice?
Yes, definitely. So I work at the Cantor Spine Center at the Paleo Orthopedic and Spine Institute. We have Dr. Scott Raffa, a neurosurgeon, Dr. Jeffrey Cantor, orthospine surgeon. We collaborate one-on-one with our surgeons. Even when it comes to MRI reviews, CT scan reviews, if I have anything that I'm concerned about or a question, I just show the images to our counterparts, our surgeon counterparts, and they really help us with a treatment plan.
And I know that opioids are still being used heavily to treat chronic pain, but that's not, it's not an answer, right?
So yeah, going back to the whole interventional pain, there's no good pain medicine, unfortunately. Yeah. It can be addicting, cause many other side effects like we went over earlier. There is a place for it, right? Patients who've been on it chronically, the kind of medication that they're kind of been maintaining on. And of course, if you have acute fractures, sometimes it is appropriate, but most of the times there's other better options.
Right. I find that a lot of times when people get started on them, they tend to continue on them because they might help alleviate the pain, but we're still not getting to the root source, right?
Exactly. I had a patient a couple of months ago, actually, this is really struck me. I had a mid-30-year-old patient. He was an MVA. He had full spine pain, neck, mid-back, low back.
Motor vehicle accident.
Sorry, yes, motor vehicle accident. He had neck, mid-back, low back pain. I got MRIs to evaluate because he just had x-rays and CTs in the ER. His MRIs looked pretty good. And I even asked him, like, how in a physician put him on opioids. And his pain VAS scores, pain level scores weren't really high. Yeah. So I was like, hey, let's try to wean off it, do some physical therapy. He came back to me maybe 4 or 6 weeks later, and he's like, I'm doing good.
That's amazing. Great. I love hearing that you help people, get better, actually. And we're not just putting a Band-Aid over it.
Yeah. No, we really care at the Cantor Spine Center. Like, I treat every patient like a family member.
And even though you specialize in spine, you, with your background, you'll actually evaluate, like you said, shoulder, knee, hip pain, and you can also do injections with those areas as well. Is there anything other than just a cortisone injection that you recommend, or do you ever? I don't know. You don't do epidurals there?
No.
Okay.
Great question. Yeah. So going back to my physical medicine rehab background, we're really good non-surgical orthopedics. So it's not just the spine, hip, knee, shoulders, foot, ankle. I'm really good at evaluating those joints. And again, we do steroid injections for all those peripheral joints, but I also do platelet-rich plasma. I'm sure a lot of people listening have heard about that before. So it's a procedure we do in the office. We draw the patient's blood, we spin it down, we separate the platelet-rich from the platelet-poor blood, and platelet-rich is high in regenerative factors. So we basically draw it up in a syringe and we inject that platelet-rich blood into the patient's joint.
And it promotes self-healing, right?
Yes.
I mean, it's your own blood, but it's just got more of the proteins for healing.
Yeah, exactly. It has all the proteins for healing. And I tell my patients too, you got to listen, sometimes you don't get the immediate relief from the PRP because it causes that inflammatory process, which is what you want. So it's very important to give it some time. And it's important to do some physical therapy after a week or two once the injection's done, just kind of help with the range of motion and helping the regenerative process.
Is that a one-time treatment or is it something that you repeat?
You can repeat it. Yep.
Okay. I have had some people have relief with just one time.
Yeah.
Okay, great. And do you recommend, or not recommend, but we always have people when they do get imaging or an MRI, we recommend that they get the disc from the imaging center and they bring it to you for a review. Is that something that you would definitely, like, you enjoy looking at the disc and imaging yourself?
Yes, the biggest thing I tell my patients when we send them for MRI imaging, I tell them to bring me the disc. Once you bring me the disc, we'll pop it on the screen, we'll go through everything.
Perfect.
And is there an age limit to who can have interventional procedures done?
I usually treat patients 16 and above.
Perfect. Well, I think this was very informative. I don't know if there's anything else that you want our audience to hear about you.
No, thanks for having me. Just going back to where I work, the Cantor Spine Center, the Paleo Orthopedic and Spine Institute. I'm not sure if anyone listening has heard of the Paleo Orthopedic and Spine Institute, but they're really big in child orthopedics in West Palm Beach. We have offices in West Palm Beach, Jupiter, now West Boca, where I'm mainly in the West Boca office, and Fort Lauderdale. So I'm in West Boca Monday through Thursdays, and Fridays I'm in Fort Lauderdale.
Okay.
Yep. And we're, again, going with being in the Paleo Orthopedic and Spine Institute, we have hip surgeons, knee surgeons, shoulder surgeons. So we have a really wide network. And I pride myself and I can help most of my patients, but if I can't, we have a really good surgeon that I could send you to help you with your pain.
Excellent.
Perfect. And you also have social media.
Yes. So you can find me on Instagram. I'm Dr._Chhatlani.
Perfect. I'm going to have everything. I'll have your address and phone number and your social media handle in the show notes.
Great. Thank you so much.
Thank you for coming on.
Thank you.
Thanks for having me.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.